Good afternoon, or morning, or evening, wherever you are around the world, and thank you all for joining our special webinar today on where we'll be discussing where we are now with the global rollout of the COVID-19 vaccine. And this webinar is hosted by the Jameel Institute and the MRC Centre for Global Infectious Disease Analysis at Imperial College in London. So my name is Azra Ghani. I'm a professor in infectious disease epidemiology in the School of Public Health. And today we are joined by three fantastic panelists who will share their views on the opportunities and challenges that the COVID-19 global vaccine rollout has presented. Before I hand over to our speakers for their opening remarks, I just wanted to mention a couple of things. Firstly, following the introductory remarks from each speaker, we will move into a discussion, and we'd really encourage you and welcome questions from our audience. So if you do have a question, please pop it in the Q&A function which you'll find on the right-hand side of your screen. Please do also vote on the questions you like, as those questions will be prioritised in the list and shifted to the top. And also, finally, remember, if you'd like to post your questions anonymously, you can use that function so that your name doesn't appear. Secondly, this event is being recorded and will be available after the event to watch again, and a link will be circulated. So now straight on to our speakers, and first we're delighted to be joined by Professor Heidi Larson. Heidi is a Professor of Anthropology, Risk and Decision Science, and is the founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She's also a clinical professor of health metrics science at the University of Washington in the US, and guest professor at the University of Antwerp in Belgium. Professor Larson previously headed Global Immunisation Communication at UNICEF, chaired Gavi's Advocacy Task Force, and served on the WHO SAGE Working Group on Vaccine Hesitancy. And the Vaccine Confidence Project that she heads is also a WHO Centre of Excellence. So Heidi, over to you.
Thanks very much, Azra. And sometimes I think the panels on COVID are more like the news channel because they change on such a frequent level. And with the title of Where Are We Now? The good news is it looks like over 1.5 billion people around the world, or doses, have been administered, which is a lot. And I think something to be in 176 countries. So it's pretty remarkable that just over a year into having kind of characterized and identified that we were in a pandemic, we've come this far. But the reality is that 10% of the population, that the global population that has vaccines available, is very much in the wealthier countries, the higher income countries, and there's a veritable desert in terms of vaccination in Africa, and India has only 3% of the population vaccinated, and as we all know, is in dire need. And they themselves are one of the bigger producers of vaccines. So the connectedness of it all is dramatic, because India was also meant to be a supplier for so many countries, including Africa, for COVAX, the global facility for vaccines. And we've seen the knock-on effect of the tension between nationalism, and sometimes that nationalism is very much, some of it's politically driven, but it's also, I think, instinctive. You want to keep your country healthy, but at the same time appreciate the world, and there's a real tension in that. And that tension has even played out in this past week, in this past few weeks, I should say, but particularly came to a tense point, is around the issue of vaccinating children. Pfizer-BioNTech announced early in the month that their vaccine was safe for 12 to 15-year-old children. The US, Canada first introduced it into their program, and then the US and the UK is discussing it, and other countries are discussing it. But WHO was sending an alert saying, wait a minute, that population's not at high risk. We need vaccines in parts of the world that need them. So there's this, at many levels, we start to fix one problem or see one solution, and then we have to think about the implications, not only implications for other parts of our national programs, but globally. In the area of confidence, that's been another challenge. I mean, on the one hand, particularly in the early wave of vaccines becoming available, there's been fantastic confidence, way beyond what some of the surveys were predicting. On the other hand, these vaccines were being rolled out, the initial part, in the thick of a pretty serious second wave. So the reason, the motivation to get vaccinated was there. There was limited supply, which also motivates people. If they see a threat and know there's a limited supply, it's a motivator to get what you can. And also at the end of the year, we had such good news about how effective the first news about the effectiveness of these COVID vaccines was. So that all raised confidence considerably, but now a few months later, we're starting to get to more difficult populations. The threat of what the wave was in the middle of the winter has waned a bit, at least in some places. So around the world, we see different stages of confidence, pockets of resistance coming up, but on the other hand, places like India with very high demand, but no vaccines. So it needs at the same time, local considerations and global, as I was saying before. The two other topics of conversation that have been going around are about pregnant women. There have been recommendations that pregnant women should get vaccinated, and I know today there was some news in Nature, or this week, about how much more serious COVID affects pregnant women. So, which is all the more motivation that they should be vaccinated, because of COVID infection can be very serious for someone who's pregnant. And then there's the issue of passports, which we've just, at the Vaccine Confidence Project, just recently finished a study. And it was 17,000 people in the UK about a number of issues around vaccines, willingness, acceptance, but a broader mix of issues. And one of them was on their willingness or support for vaccine passports. And what was interesting is that those who were positive about vaccine and were vaccinated were happy with the notion of passports, especially for international travel, less keen for domestic use, for going to the pub or whatever. But for those who were hesitant about getting vaccinated, the notion of a passport made them even more hesitant. Probably for some of the same reasons that their hesitancy might have been related to distrust. And so the idea of a passport gave more anxiety rather than less. So these are the kind of nuanced differences we need to be paying attention to at this point. And I think I've been around the block with some of the headline issues that certainly has come across my desk in the last weeks. And I look forward to turning over to other panel members. Thank you.
Thank you, Heidi. Okay, so our next speaker is Professor Anthony Harnden. Anthony is a professor of primary care at the University of Oxford, a general practitioner and also a fellow at St Hugh's College. His research interests are in infections and paediatrics in primary care, specifically common childhood infections, vaccine preventable infections, and the early diagnosis of rare but important childhood diseases. I'm sure many in the UK will be familiar with Professor Harnden's name, since he has been the GP member of the Joint Committee of Vaccination and Immunisation here in the UK since 2006, and also Deputy Chairman since 2015. And for those who aren't in the UK, this committee, JCVI, advises the UK government on vaccine policy, including the current COVID-19 vaccination programme. So, Anthony, over to you.
Thank you, Azra, and thank you for inviting me, and warm welcome to all the attendees. Of course, JCVI is the Joint Committee on Vaccination and Immunisation, as Azra said. It's the committee that no one had ever heard of before the pandemic, but now everybody's heard of. And our role really is as an advisory body to government. We don't set policy, but we do give advice, and then it's up for ministers to decide. Thankfully, during this pandemic, ministers have actually heeded our advice and gone with our decisions about vaccination, which we're very pleased about. The core membership is about 15, although we do act as a COVID subgroup, so there are a few additional members. And of course, we have a wide spectrum of people that have an input, from vaccinologists to mathematical modelers, immunologists, people in primary care like myself, and even lay representation. So the discussions are often very fruitful. There are a number of different perspectives, but we almost always reach a collective decision after listening to everybody's views, and which has been part of the strength of the committee. I think it's fair to say that the UK is widely recognised now as having a very successful vaccination programme. We've immunised 37 million adults, that's more than 2/3 of the adult population, with one dose, and 21 million with 2 doses. So we're doing very well. So I thought I'd just go through a few points. Actually, how did we develop the strategy? How is vaccine rollout monitored? What's the impact of the vaccine programme in the UK? And then we'll touch on international comparisons and a few current and future issues. And perhaps at the end, and maybe part of the discussion, we can all talk about what the end game is here, because I think that's pretty important. So in terms of the vaccination strategy, we really had a very, very simple and clear strategy right from the start, which was to save as many lives as quickly as possible. Now, that might sound a bit simplistic, but it was at the core of what we wanted to do with this vaccination strategy. And so we wanted to develop a strategy that was simple, was deliverable, and could be moved at speed. Because you have to remember, back in early December, when the Pfizer was first approved in the UK, and in late December, early January, when the AstraZeneca was first approved by our regulator, you know, the pandemic was really, the second wave was really taking off in the UK, and hospitals were being very threatened by being overwhelmed. And so actually, when we looked at a number of different data sources, and it became a bit straightforward that age was clearly the dominant risk factor for both morbidity and mortality. And that was brought home by the care home experience that we had in the UK, where a substantial proportion of the deaths were elderly people in care homes. And actually, when you looked at figures, they're quite stark, actually. You needed to vaccinate 20 in a care home to prevent 1 death, and 107 over 80s to prevent 1 death. Whereas if you look right down to the 20 to 29-year-old age group, you need to vaccinate about 116,000 of those to prevent 1 death. So it was really clear that our prioritization for the vaccine program needed to start with the oldest first, and then work our way down. However, there were a couple of nuances in this. One was health and social care workers, and we were very aware that at a time of crisis, the health service needed to carry on working. So we wanted to protect those that were working within the health and social care sector, as well as potentially they could transmit to elderly people in there that they were looking after. And so that was a good reason, even though we didn't have data on transmissibility at that point. It seemed very sensible to protect them from that. And thirdly, we just felt that they had a big exposure risk. And many people that were working in hospitals, particularly on ITUs, were having huge exposure risks. So we weave them into priority group 2. And then, of course, the other nuance was those with underlying illnesses, and some of those which were shielded in the UK. And so we prioritised them based on some estimates of the risk that they had of COVID and complications by disease group and what age those were commensurate with. So we set up a list of 9 priority groups, and which was our phase 1, and then phase 2 we've moved down through those age priority groups. Now the other big, so prioritization was the one big strategic decision we made. The other big strategic decision we made was delaying a second dose. Now this was very controversial at the time, but we made very clear calculations based on data that we'd seen both for the AstraZeneca vaccine, which actually showed that a delayed second dose gave longer and better term protection. And actually also from some of the early data coming out of the Moderna mRNA trial, which again was showing that those with a delayed dose still had good levels of protection after 1 dose. And so we had a lot of experience with other vaccines where we've actually reduced the number of doses given for other vaccines. For instance, HPV is a good example of this. And so all this combined with our estimation that we would see a substantial effect, protective effect after that first dose, not as good as with 2 doses, but a substantial protective effect, and that we would be able to save more lives by a strategy of vaccinating more people rather than a strategy of vaccinating smaller numbers of people but fully vaccinating them with 2 doses. And we calculated that this would probably save somewhere in the region of about 4,000 lives per million doses. So that's why we made the strategy. It was controversial at the time. But in time it has proved a correct strategy. Now, what we do on JCVI is we monitor coverage and safety. And the coverage has been fantastic in the UK. We've motored through this programme. By mid-February, we'd offered a vaccination to those within priority groups 1 to 4. By mid-April, it'd been 1 to 9, and we hope to offer every adult a vaccination by the end of July. Coverage, for instance, of those 1 to 4 groups, that's those 70 and above, has been 95%. And it's been really good with the uptake of the second dose after 12 weeks as well, which has been around 96, 97%. We still have a bit of a problem in harder to reach groups, and the NHS is working very hard. Certain ethnic minority populations, certain deprived populations are not taking the vaccine up in the same high percentage as the overall percentage. And so the NHS are working very hard at not only convincing those that may be hesitant by working with local clinical faith and community leaders, but also by making vaccines accessible through mobile units, pop-up sites, etc., and actually even offering immunisations in religious centres such as churches and mosques. The other thing we've done on JCVI is we monitor safety, of course. Safety is absolute paramount. It's one of the reasons that we shifted for pregnant women recently because of the experience in America of using lots of mRNA, Pfizer and Moderna vaccines in pregnant women. We decided that we would offer pregnant women the alternative vaccine. And likewise with the emerging data about the rare but important adverse event of thrombosis and thrombocytopenia in the AstraZeneca recipients, slightly graded towards younger age, and on clear risk-benefit calculations we did, we felt that there was enough supply and alternative to offer under 40s in the UK an alternative vaccine whilst infection rates were low. although if infection rates go up, that risk-benefit equation may change. In terms of the impact, it's monitored by Public Health England, the Scottish authorities, there's studies in healthcare workers, in elderly care residents, and it's really clear one dose offers about 65% protection against disease, about 80% protection against hospitalisation, and 2 doses offers about 90% protection. There's also data now showing that transmission is probably reduced by up to 50% in vaccine recipients, and Public Health England have done lots of calculations to show that the vaccine programme to date has saved about 11,700 lives. So it's prevented 11,700 people from dying and 33,000 from going into hospital. Of course, that's the estimate that it's done to date, but of course these future estimates will be much higher because those vaccinated individuals will not be getting severe COVID in the future. In terms of international comparisons, I think we've done pretty well in the UK. I mean, Israel have done fantastically well, as we know. Europe have lagged behind because of different decisions that were made at times. For instance, the AstraZeneca vaccine was not used in older populations initially because they didn't feel there was enough data, though we were pretty clear that the data was pretty compelling. And of course, more recently, the not using it in the younger groups, but now using it in the older groups. So there's been a lot of stopping and starting in Europe, but I believe they're catching up at the moment. I think India were lulled into a false sense of security after their first wave, and the second wave has really come back to bite them, and they've got they've got a massively large population, but proportionally not many vaccinated. I think the US have caught up with the new administration. Canada have lagged behind. Chile have used different vaccines. They've used some of the Chinese vaccines. And I think, as well as the Pfizer vaccine, and I think there have been problems, but maybe one of our other speakers can talk more detail about South America. In terms of current and future issues, the variant is a current issue. That's the B1617.2 variant, which originated in India. In terms of vaccines, we do believe the vaccines are still very effective against severe disease for this particular variant, but we're still working out whether how much the vaccines are good against transmission of mild disease for the variant. Things are promising, but we're not clear on that yet. Looking to the future, we need to think about boosters. Whether we need a booster, how long does duration of immunity last, who do we boost, do we just boost priority groups or do we boost the whole population? If so, what do we boost them with? Different vaccine types, there's studies going on about mixed vaccine schedules, variant vaccines, and when we deliver this vaccine, whether it be the autumn or later in the year. As your previous speaker said, Heidi said that children are a big issue. Of course, 26% of the global population are under the age of 15. So this is a very big issue. 12 million under 16 in Britain. There are lots of ethical issues, though, about this in terms of vaccinating children potentially to prevent infections in older people, vaccinating children at the expense of distributing vaccines elsewhere in the world. But some children do get sick. They are a minority, very, very small minority, but some do. So there are lots of things to discuss then. And then perhaps just to conclude, we need to start thinking about what the end game is here. I mean, it seems unlikely that in the world that we're going to completely eliminate this virus. So I think we're going to have to come to terms with living with it. It's just a question if we can get a substantial proportion of the world vaccinated and protected, particularly in those in at-risk groups, then it may be that the circulating virus actually ends up giving natural boost to some of these individuals, and that's the way that we live with it. So it becomes a mild disease in young people and a booster opportunity in those that are vaccinated that are older. But these are all things for the future. And I think I'll stop there, but I'm I'll be very happy to answer questions at the end on the panel.
Great, thank you, Anthony. So finally, we're delighted to be joined by Professor Julio Croda. He was former chief of the Department of Communicable Diseases at the Secretary of Health Surveillance in Brazil. And previously, he was Associate Professor of Epidemiology in the Yale School of Public Health and a specialist in science and technology and production and innovation in public health at the Oswaldo Cruz Foundation, which is also in Brazil. So thank you for joining us very early in the morning, and over to you.
Thank you for the invitation for this great event. It's a great opportunity to discuss COVID-19 vaccine rollout, especially in the context of middle-income countries. It's very good to have an opportunity to say some words about this. Especially in Brazil, we have a big problem with COVID-19 since in the beginning. You have a president that denied the COVID-19 pandemic. They said that is not a big problem. They didn't reach and support the no pharmacological intervention. They not buy enough vaccination in timely opportunity that have in 2020, and you have a huge impact in the country. I think the majority of yours see in the television, in the newspapers, what occurred in Brazil and in several countries in Latin America. This is not only Brazil, but occur in Peru and in some cities of Mexico, that you have a shortage of oxygen, shortage of ICU bed, and now this occur especially in the India also. And in the south hemisphere, the countries suffer more than the north hemisphere, especially because they didn't have social support to deal with the pandemic COVID-19. The poor population need to go out, need to work, and it's very difficult to impose restrictive intervention, especially to put some restriction, to leave the people, to keep the people in your house, to prevent the transmission. In this context, without the test, especially in the majority of the south countries, you have a high burden of this disease. When you pick up the top 10 countries in the incidence and the mortality, the majority of the country in the south, and you have a lot of countries, especially in Latin America, in the South America. And Brazil is the second in the number of the deaths, have a high incidence of the cases also, and now you have a problem with the vaccine rollout. And nowadays, you vaccinate really nice numbers, more than 30 million people get a shot of vaccination, but still very low coverage. It's about less than 10% of population that receive 2 doses of vaccine in Brazil. And this is a problem because take time to vaccinate the entire population. You just end the second wave in a couple of months ago, and now we have an increase in the number of the cases, especially in the south, especially in the southwest, related to the winter time. And this is common in Brazil. We have a more circulation of respiratory virus during this time, and you have a very difficult support for the federal government to impose restrictive measures. This is the context of Brazil, but probably this is the context of another countries in the south, especially in Latin America, especially in the South America, and you have big problems with the vaccination rollout. In the context with the new variant that's more transmissible, you don't know about the pathogenesis, maybe it's you have the burn is it's higher in the younger population. You're not sure, you don't have any data that support this information. And when you think about the vaccination, the majority of the country, especially in the south, the majority of the country go to the COVAX facility. It's the main source of the vaccine. But Brazil make a different deal. They try to develop your vaccines, especially use the two public labs, Butantan and Fundação Oswaldo Cruz. And you have an agreement with Sinovac to produce Coronavac in Butantan, and AstraZeneca Oxford vaccine in the Oswaldo Cruz Foundation. This tech transfer is good because it gives some independence of the country to produce your vaccine, but you continue need to this tech transfer. This is not finished. You need to import the pharmaceutical product from China and to do the doses necessary for the population. This continue to do in Brazil, and probably until the end of the year, you have opportunity to begin the production in the country. But in the context, I want to point out, in the context of the COVAX facility, you have some delay, especially because India is not able to produce the number of vaccine necessary to support the WHO, and this is a big problem. And in this context, you have a lag of 3-6 months compared to the poor countries and developed countries. This occurs in the influenza pandemic H1N1, and this repeat now. You have this difference between rich and poor countries, especially in rule out the vaccines, and especially nowadays where you have a high burden of the disease. India, South America, and didn't have enough vaccine because it didn't have some delays in the COVAX facility to deliver these doses to the South countries. And this is opportunity for the world, for all the countries to understand and try to deal with this difference. How to deal with this difference in the next pandemic event. You continue to have the difference between poor and rich, especially related to rule out the vaccination, and not only the timing to give the vaccination, but the difference of the vaccines. You know that during this time, the majority of more efficacious vaccines was concentrated in the north countries. And you can say that the majority of the Pfizer and Moderna vaccine now it's give to the rich countries, and the majority of the poor countries needed to deal with inactivated vaccines, some adenovirus-based vaccines, some vaccines that's not approved in the general regulatory agents like Russian vaccine Sputnik V. And this it's not only the difference among the what percent of population needed to immunize it, but the quality of the vaccine that is rolled out in this country. You know that is inactivated vaccine, especially Coronavac and Sinopharm vaccine, produce low neutralizing antibodies, probably have a low efficacy and effectiveness, and especially in the old population, the population that have high risk to hospitalization and to death. And this is a big challenge. How you change this discrepancy in the world, and you need to think about the patent, but not only to broke the patents, but also to improve the velocity of tech transfer among the countries, among the companies. This need to lead by WHO. You need to put effort to deal with this. And thanks for the opportunity, for the invite to stay in this very nice panel to discuss the vaccine rollout in the world.
Thank you very much, Julio. So just before we launch into some questions, and I can see quite a few appearing, I just want to remind the audience that please do type in any questions you have as they sort of arise in your head, and also to vote on any of the questions, and we'll try and take some of those first. So I'm just going to start actually at the one at the top. So there's a question about the AstraZeneca vaccine, and we know it's hit many bumps in the road. And do you think its credibility is now too damaged for it to be taken up as widely as was hoped? I mean, maybe Heidi, you could start here with your thoughts on that.
Well, I always like to think it's never too late. It has been a rocky road from the start with some uncertainty and changing information. But I think that I do think that it has a clear and a very important role in the world, and I think that the issues around some of the safety events are very clear now, and there have been policy decisions made based on that information. I think moving forward, particularly given the scarcity of vaccines in the world, it's going to be really a really important vaccine, particularly for the remaining countries. Also, I mean, with this very, it seems to be good. I don't know, it's over to you on this, but it's sounding like it's also protective against the Indian, well, what's being called the Indian variant, but actually the Indian outbreak started with the British variant. So there, it's not that straightforward. So I think absolutely, but I think we really need to learn from, where there have been some misunderstandings. But I think from the beginning, we have to remind ourselves that we're all learning as we're going. So I think we've come a long way on that vaccine.
Great. And Julio, I was going to ask whether...
I think Anthony wanted to add something.
Okay. Anthony.
Yeah, I was just going to add that these vaccines are astonishingly good, and the AstraZeneca is such an important vaccine for the world because, of course, it has to be stored at refrigerator temperature, and the mRNA vaccines really, with their requirement to be stored at much lower temperatures, are just not feasible to give the rest of the world. So I mean, it's an astonishingly good vaccine, and the bumps that it's had along the road about the data in the older people hasn't proved to be true. The safety signal is a very, very rare adverse event, and we must remember that any drug and any vaccines do have adverse events. The only reason that we've made a decision in the UK is because our infection rates were very low at the time, and the incidence of complications was from COVID was less than the incidence of adverse events, which is 10 to 20 per million. But you have to remember there are many countries in the world, for instance in Africa, where the life expectancy isn't much above 50, and of course their risk of complications from COVID at a younger age group will be far higher if they've got high incident rates. So we mustn't bash this vaccine. I think it's going to be an incredibly good vaccine for the world, and I think we were very conscious of that when we made our decision on JCVI, but ultimately our decision was based on the UK epidemiology. It wasn't based on the world epidemiology. And so, for instance, in India at the moment, you'd cut your right arm off to have the AstraZeneca vaccine if you were in your 30s. So it's very different. The message needs to go out. This is a safe and effective vaccine.
Yeah. Thank you, Anthony. And actually, Julia, it's on a related point. You made an interesting comment about sort of the different vaccines that are available in the Southern Hemisphere, and particularly the inactivated vaccines. Do you see that there's a perception of an inferior quality of vaccine being delivered?
You needed to take care with this message for sure. It's one vaccine is better than don't have any vaccine for sure. Yeah. Like Anthony commented, it's better to have AstraZeneca. It's better to have inactivated vaccine than don't have any vaccine. But you needed to deal with in the next filter. How? Because you know that this vaccine have a low global efficacy and effectiveness, and probably not deal with the transmission, probably not to reach the herd immunity with this kind of vaccines. They prevent hospitalization, they prevent deaths, probably very nice data that greater than 80%, but not control the transmission. And you have two different messages in the North Hemisphere and the South Hemisphere. In the North, the people, like CDC said, take out your mask if you are full vaccinated with Moderna and Pfizer. Here, even you have a high vaccination rate, you continue to need to do the no pharmacological intervention. You continue to need to use mask, especially because this vaccine is delivery for prevent hospitalization death, not to prevent the transmission. And this message need to be clear.
Great, thank you. Okay, so we've got one popular question so far, which is about original antigenic sin. So it's quite a tricky one. So given that the immune system's memory the first vaccine received against a particular virus can impair its response to the slightly changed later versions of the vaccine, does this mean that if booster shots are needed in the future, it might be better to stick with the original vaccines to build up very high antibody levels rather than using the modified vaccines that have been designed specifically for these new variants? Anthony, I don't know whether you want to give a first thought on that. I'm sure the data's quite lacking at the moment.
Well, it's just a very difficult question to answer. I mean, it's a very interesting question, but it's a very difficult question to answer. We don't really even know how long the duration of immunity lasts for after natural infection or after vaccination. And so actually to ask the question about what happens when we do to the immunological system when we do a booster vaccine, either with the same or a different type, is unknown at the moment. There are studies going on in Oxford looking at reactogenicity as an outcome measure for mixed vaccine schedules, but they are looking at immunogenicity as well. And so we will have some preliminary information from those studies run by Matthew Snape in Oxford, which might partly answer the question that your Clive is posing here. But I think the answer is this is just such a new illness and such new vaccines that we don't really know, and that's why actually the booster decision is actually a very difficult decision, because we may end up giving some policy advice based on some information but not complete information.
Right. So actually related to this, of course, if we start to give booster shots in high-income countries this coming autumn, then that's going to cause quite a demand in terms of the issues we have globally with supply. So there's a question about at what point should the high-income countries be sharing the vaccine doses that are available with the low and middle-income countries. And I can see Julio's nodding, so maybe I'll give him the first word on that.
Yes, this is a discussion that you needed to deal and understand better this. I think it's like in the beginning, you need to use all the vaccination that you had, give access to the global population for any vaccines. But in the future, in the next years, you needed to deal with the best vaccine, especially to control the transmission. And the data come out during the last months, and probably in the next months, you have more data about this and comparison among the vaccination, different schemes. And you need to deal with this. I think it's very hard. It's very hard decision, but this decision passed through the patents and tech transfer. You needed to push the company to especially try to work with the governments, public labs in the south to accelerate this tech transfer. The problem is not the patent per se, because you have support from the United States, you have support from China related to the patents, but you need to accelerate the tech transfer. You need to build capacity in the South countries to produce your vaccines, especially the better vaccines, the technology based in RNA that show that have impact in the transmission. And you need to transfer this tech to the public and private labs in the South countries. This need to leader for WHO and needed to push the companies to do this very early now to plan for the next year, in the next 2 years.
Great. Heidi, I don't know if you want to comment a little bit about the global allocation of vaccines so far.
Yeah, I mean, I totally agree with Julio. It's the point I was raising with the children, even vaccinating children, although there's a different good reasons for that in terms of reducing, as Anthony also said, the spread of disease with adults. But I think this is going to be the burning question. I mean, I would think by the time we're thinking about getting boosters, hopefully Serum Institute and other production might be up to speed in a different way than right now is a difficult moment. And that's been one of the challenges of the current environment we're in, that, you know, we're so caught in what the current crisis of the moment is. It's sometimes hard to look ahead, but I think in terms of production, hopefully in 2-3 months, we'll be in another place with more production. So there should be more supply, and so the option of a third booster. But I think there's also the questions that, again, Anthony had raised about, you know, we don't really have a whole lot of information to really know whether we actually need the boost or if it's the right one. But anyway, I think we have to, it's going to be an open slate to keep discussing as we weigh the amount of vaccines available, the pressing need, and where it is, because who knows? I mean, we could see Africa, some major African cities with a resurgence. There's a lot of traffic back and forth with India and Africa. Who knows? We'll be in a different state by then.
Yes, and that of course brings us on to the topic of India, and we have a question here about what the vaccination strategy for India should be in the wake of the second wave that's currently devastating the country, and possibly also the region, as you say, Heidi. They'll be moving across South Asia. So, I mean, Anthony, you mentioned, you know, very much the strategy in the UK was to save lives. So, should that be the same approach that should be adopted in India at the moment?
I think they need to vaccinate their older population as quickly as possible, and that's obviously a bit simpler in a country like ours. It's got 66 million adults, or 56 million adults, and 66, 70 million people, than it is in a country that's got a bit more than 1 billion, and that's very difficult. But I think that Serum Institute will increase capacity, and they need to target their vaccines even at the moment to perhaps a one-dose strategy in older people. That would be my advice. Mm-hmm. Now, whether they've got the infrastructure out there to do it, I mean, that's of course, we talk about vaccines and supply. The other thing, of course, is vaccinators, isn't it? And we've been very lucky. We've got a National Health Service in this country which has stepped up to the mark, and we've really got a very large vaccinator capacity now, which we built on through primary care. With other centres like mass centres and pharmacies and hospital hubs and things, but we had a very strong vaccinator capacity anyway in our country, and I don't know quite what they have in India, and it may not be as good in other countries, but maybe they need to look to the mass vaccination centre model that we've developed here.
Yes. So, Julio, obviously Brazil's been experiencing exactly what India is now experiencing. So, what can we learn from what has happened so far in Brazil and how to go forward?
It's a hard time for India, and you needed to understand that maybe on other countries that have access of vaccine, maybe to help the Indian population, and it's very difficult in the poor country. Have different social difference, like the castes in the India, the poor and the rich. The difference is very high, like in Brazil, and it's very difficult to keep the poor population without any social support inside your homes. It's very difficult to do isolation in this population to decrease the transmission. The vaccination probably not impact in this second wave in India. It's have some delay. You need to reach a high level of percent of the population that need to be vaccinated, and you need. I think the main advice, if I give for the Indian government, try to do some social support, especially to improve, to decrease the circulation. But it's not only the communication to the people, try to keep in your homes to decrease the transmission, but need some social support, especially in the vulnerable population, for try to reduce the transmission, because the vaccine in this short of time, especially during the second wave, you didn't have a huge impact now. It didn't have opportunity to accelerate this vaccination. The Indian government needs to work with the no pharmacological intervention.
Great. And actually, just to follow on from that, there's a question here specifically about Brazil, and obviously you have an ongoing threat, perhaps, with the P1 variant still circulating, of a third wave. So what do you feel the country needs to get in place before that emerges?
Probably based on your vaccination rollout, you have a third wave. Mm-hmm. Not only because the velocity of the vaccinated rollout, but because the majority of vaccination that you use, it's a CoronaVac. It's 80% of the population was vaccinated with CoronaVac, and it's very this vaccine is not designed for stop the transmission, especially in the south, in the southeast. And nowadays in Brazil, we have a big problem in convince the stakeholders to implement no pharmacological intervention. I think maybe in some cities, in some states, especially in the southeast, during the winter time, the third wave can be worse than the second wave. It's a crazy situation, but you needed to deal with this in the next 1-2 months.
Yeah, absolutely. So there's a question here that says, beyond the problems with the supply chains, which we all are very aware of, an effective vaccine rollout in low middle income countries can be impaired by a lack of trained vaccinators and the delivery platforms I started to touch on. So maybe Heidi, you could say something a little about, from your experience in particular with working with UNICEF, how existing health services have been successfully adapted to deliver vaccines effectively.
Well, This one is more challenging because it's not a childhood vaccine. Well, not primarily anyway. So, I mean, you still have those locations available, but I think in this case, as we've had to do in the UK, expand the scope of locations. It's a bit more along the lines of the polio vaccination eradication initiative, that even though that is children, it has gone, way beyond the health center in terms of, vaccination points and needing mobile clinics. And on the other hand, I think anything that COVID and COVID outreach can do to strengthen underlying system is going to be crucial, because they've also, I think number of these excess deaths are due to other things that were not attended to because of COVID. So, and we have really, I think, a lot of children who've never gotten vaccinated in the last couple of years because of COVID. And particularly, we're particularly concerned about measles outbreaks, that some of the other vaccines, are for things you might get in the longer run, but measles has quite an immediate, you can get pretty immediate outbreaks with under vaccination. So I think the more you can bundle COVID vaccine with other things, the better. But again, it's the challenge is kind of the scope of the age is different. And a lot of these particularly poorer countries don't typically give adult vaccinations. They don't give flu vaccines. So we don't have those kind of opportunities. But it does push people to think differently, and maybe that'll have a positive knock-on effect on systems more broadly.
Sure. And actually, it also occurs to me that these vaccinators are the same people that are trying to run the childhood immunization program. So there are limited staff in any of these settings.
And they're also the ones who are getting sick themselves. Yes. I think we've underestimated the toll that has been taken on the health workforce itself, which is another challenge.
Yeah. So, of course, one of the issues that's facing us all at the moment is these variants of concern, and we here in the UK have the worry about the recent strain emergence. So there's a question about that one specifically, but of course it's true of any variant of concern. How quickly can we actually adapt and vaccinate against these new variants? And we will be in a never-ending cycle of trying to race after the next variant that emerges. I don't know if Anthony wants to.
Yeah, I'm not as worried. I think we're just going to have to get used to living with variants. I think this is what's going to happen. There are all these predominant variants we've heard about because of their transmissibility advantages, but there are thousands of different variants already out there, and there will be many, many more to come. I think the really good bit of news is that these vaccines are so effective, and even against variants which emerge, the effectivity against severe illness, that's hospitalization and death, are holding up for all the variants we've seen to date. Now, the problem is that of course it's the milder end of the spectrum. So what people will get is maybe a milder disease. They will be able to transmit, but they'll be protected against severe disease, and they'll get a boost. And so it goes back to Julio's point about transmission. Actually, if you've got an unvaccinated population, the variants do become more of a concern because, of course, they're more transmissible, and they will go through the population and they will attack those unvaccinated individuals that are in high-risk groups who won't be protected. So certainly the vaccination is the way out, and I wouldn't get so worried about, in a vaccinated population anyway, about variants. I think it's more of a concern globally to unvaccinated populations.
Yep. Julio.
Yes, just a quick comment. I totally agree with Anthony, and you needed to deal with these variants in the world. The majority of the studies that perform, especially effectiveness studies, the real world, show that vaccine continue to work. Even the inactivated vaccines, even the another platforms vaccine continue to work for this variant. But I think you needed to develop some system like influenza system that you have some immunological correlation of protection that you can understand during the time in the next future if this variant, this increase in the mutation based on the transmission have any impact in the vaccination herd immunity, the impacting the increase of the number of the people that being hospitalized or death. And it's very difficult to perform like a clinical study every time that you have a new variant. You need to deal with your surveillance system that already captures severe cases, try to identify some partners that probably lead us to understand that new variant can impact it, you have a less immunity for the old vaccines for this new variant, but you needed to check, as you did for influenza, try to validate some immunological correlation of protection to deal with this in the future. And if necessary, like the influenza, you can change the vaccination each year, each 2 years. But you need to have something that's more quickly to understand this variation and to validate this in the field for your future, be more easy to every variant that surge in the world. You need to do a study, clinical study, to understand if you need to change or not the vaccine, if you need a booster or not in the future.
Great. So moving topics slightly, we have a question here about vaccine uptake. So it's said that vaccine uptake in the UK is low in certain demographic groups. What are some of the reasons, perhaps aside from religious objections, that could cause this? And how do you expand on what is being done to reach those hard to reach groups? Heidi, do you want to start maybe?
Sure. I mean, we still, I think we've had a good improvement in some of the Asian population, particularly the Bangladeshi community, which was hit very hard in terms of serious illness and mortality. And I think there were some pretty creative ways to try to engage the community. I mean, even kind of restaurant owners getting out there saying, get vaccinated. And I mean, it was quite some novel approaches, and their uptake has gone up. We still have, I think, some of the more of the resistance in the Black community, and that's going to take, I think, a lot more engagement and work, because some of that is some of the deeper distrust issues that are consistent with some of the background things we've learned in the childhood vaccination program. But
and Anthony, I'm guessing you see this in your daily practice.
Yeah. Well, actually, not so much in our own practice, but I agree with Heidi. I think there's a problem in certain minority groups about confidence in institutions and authority, and I think that is playing into some of the decisions about not being confident about the vaccines, and that's where I believe that local leaders and local efforts really will help. And you've only got to look at Bolton now to see many more of the older people in certain wards of Bolton are now coming up to be vaccinated that hadn't been vaccinated before. And so I think the message is getting out there. So I think it's a matter of confidence rather than hesitancy. Of course, the other problem is social media. And social media does give a platform to people with views that aren't mainstream, and those can quickly go viral and cause damage in confidence. So I think it's something we need to work at. I think it's something we need to be very worried about, because, of course, we do know that being in an ethnic minority group in the UK anyway is a risk factor for severe disease. And, those are just the populations that we want to reach out to. So if we've got lower coverage rates, which we have, particularly in the Black African and Black Caribbean groups, then that is a big problem for us as a society and for them as individuals.
And Julio, I mean, reaching some populations in Brazil is, of course, very challenging, given the remote places that they live.
Yes, especially the indigenous population in the Amazon, in the Mato Grosso do Sul state, that is the border of Paraguay. This is very difficult, and you have problem with social media. And indigenous population. You have church leaders that it's most the time it support the Jair Bolsonaro president, and they have some conflict with the vaccination in the beginning, like the people that give a shot of vaccination transform in crocodile, and all these things go to the church leaders, and this spread in the indigenous community, and have a low rates of vaccination. The indigenous population that is a priority group in Brazil is the first group that give the vaccination, and the vaccination cover it's lower because this communication in the beginning of your vaccination campaign, and this is a problem. It's an example. It's like Anthony said, that how the social media and the communication is important to keep the community engagement with the vaccination.
Great. Okay, so there was a question here. I think we slightly lost it now, but I remember, so I wanted to move on to, obviously vaccines have been a really big thing during the COVID pandemic, and the incredible progress that has been made in developing these vaccines will hopefully have implications for the future, both for pandemic planning, but also for vaccines against many other infectious diseases that we struggle with. So I'm just wondering how what we've learned so far from both the science and the development, but also as we're learning through the implementation of this particular vaccine, how that will influence our future vaccination programs across a range of infectious diseases. Maybe Anthony, maybe have a first thought.
Yeah, I mean that's a very complicated question. I think that we will learn a lot. I think this pandemic has really impacted the world considerably. So I think we will learn a lot from this, and certainly the speed at which vaccines can be developed has just been quite incredible. And the mRNA vaccines are a relatively new technology. They have been used before, as have the viral vector vaccines before, but in much smaller numbers for much smaller outbreaks like Ebola and like Zika and things. So I do think that we've learned how to develop vaccines quickly. We've learned as a world of how to respond to such a pandemic. So I don't think this generation of our generation will make the same mistakes twice, I hope, in terms of the preparation. And certainly when I looked to the UK, we've looked at how relatively compliant a population can be faced with an emergency, both in terms of coverage for vaccines, but also in terms of the non-pharmaceutical interventions, in terms of the lockdown and things. I mean, it's quite incredible that the society has tolerated what we've tolerated in the UK anyway for the last 18 months, and so it's all credit. So I think a lot of things to be learned. I think on a global scale, I think we've learned. This is one of the problems that globalization brings, isn't it? Is transmission of infections and how quickly this spread through the world, because we're also interlinked. And we're also dependent on each other for supply chains and for everything else that actually, this is why it's incumbent on certainly the developed countries like the States, like UK, like Europe, who are well ahead with their vaccination programs, to really think very carefully about the rest of the world and what we're going to do to support them and to maintain a vaccination and a support program for the rest of the world. I think that's going to be incredibly important, because if other countries aren't safe, we're not safe. We're all so interlinked. We're so independent on each other for being safe. And I think that's a big lesson to be learned.
Yeah. Heidi, do you want to comment on that?
Well, I think we, looking forward, because there's a lot of already conversations on preparedness for the future, even though we're kind of putting out fires while we're preparing for the future. I think one thing that we underestimated was the lack of national leadership and political leadership. I mean, there's really, I think in preparedness for the future, that we need to not assume that political leaders are going to weigh in the way the world would love them to, for whatever reasons, and that we need to think of preparedness at local levels, at the level of mayors, at the level of states, at the levels of, because we need preparedness in the absence of good political leadership. If we have it, all the better. But I think we've seen in a number of countries at a national level, at a central level, it has not lined up with science, or it has been for other motivations, political or otherwise. And I think we're going to have to think about, plan Bs, and question some of the assumptions that we'd make, because we hope that in such a dramatic setting, people would put their things aside. Anyway.
No, absolutely, and it's a very important point. So we obviously have the G7 summit coming up. So maybe, Julio, is your opportunity for a question to our G7 leaders, or a suggestion. What would you like to see coming out from the politicians?
I like to deal with, especially for tuberculosis, the infectious disease that have high burden of in the entire globe. It's a big concern. It's the disease that more kill people in the world nowadays. And we have this opportunity. We have all these new platforms that develop for COVID-19, a lot of investment performed. Why you not using this platform to reach one disease that is very old and you didn't have a good vaccine for prevent active disease? I think you needed to think more in TB, especially nowadays that you have this new platform, new opportunity. It's a new window that will open for the poor country, especially that can use this platform to develop a new vaccines for old disease like tuberculosis, leishmaniasis, schistosomosis, all these diseases that it reach these poor countries. It's very difficult to do with this in the poor country without vaccination.
Absolutely. I'll add malaria there, since that's my research interest. Very important to me. So actually, we managed to discuss COVID, pandemics and vaccines, but we haven't actually mentioned economics at all, and yet these things are so important. So there has been a question about, we've had very much a focus at the moment on vaccines reducing deaths, but should we also be thinking about how they allow countries to scale back interventions and how that interacts with the economy? Anthony, maybe from the high income perspective, how are the discussions happening in the UK?
Well, I suppose from a vaccine point of view, we haven't discussed economics in the sense of we're often doing cost-effective analysis for vaccines, and we just completely bypass that because it's all been a bit of a no-brainer actually, that it's, to get society back and running again, we need to plough as much money into these vaccines as possible, which we have done. I think it's absolutely right. I mean, I think the economic impact on all this will resonate for generations to generations. And one of the things that I worry about more than anything else economically, and for the whole pandemic, is the young. And the reason that I worry about young people is that young people don't get severe COVID on the whole. They've been making huge sacrifices in terms of their lives and their education to protect what is predominantly a at-risk elderly population, and yet they're going to be the ones paying for it as well. And actually, you know, we built up, for instance, massive amounts of debt in this country, in the UK, and I'm sure other countries have done likewise. And that debt at some point will need to be paid off. And we're going to have to think very carefully, I think, economically, what the fairest way of paying that debt off is, and whether that really should fall on the younger working population, or whether it should be spread a bit more evenly. I think that's probably all I've got to say about economics. But I mean, in terms of vaccine, we haven't done any cost effectiveness discussions, because it's just been about getting as many vaccines into as many people as possible, because we know that the economic benefit is such that the classical cost effectiveness arguments don't come into it.
And I'm assuming then, obviously, we're still, of course, in the middle of a pandemic. We often like to think we're out of it every time a wave dissipates a little bit, but this could be reverberating for many, many years. And Julio, I'm sure it's going to continue to have an impact economically in the global south. So how should the world leaders be thinking through those issues?
I think you have an alternative to do this. I think you have some examples in the South Hemisphere with social protection, for weight the vaccination, and you need to reach this high-risk group. Especially, you have some data in Brazil that show that Black people, the people that live in slums, have more risk to get the disease and to death. It's like the UK. When you look at these special groups, it's the same here for the poor population. And but the percent of population that have situation, it's higher in the South countries, and it's more difficult to deal with this. But you can deal with this. I think you can have some more social support for wait for the rollout the vaccines. Like Anthony just said, it's not necessary to make any cost effectiveness study, because for sure it has a huge impact in the economic if you can get more fast the vaccination in the population, especially in these vulnerable groups that more risk to get infection and disease. But a difficult task. You didn't have a good recommendation when you look in the majority of the recommendation for non-pharmacological intervention. No of this intervention came from the poor country, and you needed to reach this good example that occur in the poor country, and try to share this experience to another country, especially to have a clear message that even in the poor country, you can implement some non-pharmacological intervention. You can implement some measures that prevent the transmission. And I think you needed to take with this and try to share with the other countries this good experience that occur. It's upon to our experience in some cities, in some communities, that work as a group and decrease the transmission, decrease the burden of the disease, and you need to show these examples to the world, especially to the South countries.
Sure. And Heidi, I know you have a lot of experience in many of the lower income countries. Are these countries going to be the ones left behind, both from a health perspective and economically further damaged by this pandemic?
Well, I think some of them already have, and I think with some of them we're not sure. I mean, Africa right now is, I think, highly underreporting what the state of things are. Just one, the testing capacity is not what it could be. On the other hand, I think there has been tremendous mobilization in Africa for African solutions. The AU, the Africa CDC have convened and mobilized, and the Pasteur Institute have really mobilized a lot of conversations, a lot of commitment to building more local manufacturing capacity for vaccines, but also a lot of countries are really, in the context of COVID, really standing up in different ways than they have in terms of getting ownership around it. The challenge there is they just haven't had vaccines, and actually, some of them have made bilateral deals with Sputnik and Sinovac, and some of them have been quite scared about AstraZeneca, even despite, there's the reality, Anthony, and then there are the perceptions. And I think that, that some of them are scared. They don't have enough, and I think it's one thing when you are faced with a situation like India, but there's also a lot of COVID denialism going on. So, when you don't really believe something is as bad as it is or can be, it's hard to persuade someone to take a vaccine that seems to have some risks. So it's a complicated space, but I do think that the experience of the pandemic and what they're seeing has pushed a lot of thinking in different ways, and a lot of people standing up for different ways of working. So hopefully that'll move things in a different direction moving forward.
Great, thank you. So I think we're nearing the end of our time now. It's been a fascinating discussion. It's clear that there are so many dimensions to this pandemic and so many dimensions that affect the rollout of vaccines globally, and we're really still at the early stages of trying to grapple both with the science, the public health, and the politics. So I just want to thank again our three speakers for their fantastic inputs, and for all, of course, the hard work that you continue to put into trying to control this pandemic. Thanks again to the MRC Centre and Jameel Institute for hosting this webinar, and thank you to all the participants. I hope you enjoyed the session, and this will be available online for you to listen to at a later time. Okay, thank you very much, and good afternoon, evening, and good morning, I suppose. Okay.
Thanks.
Thanks.
Thank you.